Welcome to the Community Development Podcast, a podcast dedicated to community development practice and approaches, sharing our learning and connecting the workforce. My name is Russell. Welcome to episode 32, the first episode of a new year of 2022. Quick shout out to the last episode of 2021 with Anna Clark, President of the International Association of Community Development. We recorded when the COP26 summit was taking place in Glasgow, the Climate Justice, Climate Change Summit, and using that as part of the context in which we were chatting with Anna. She was able to talk a bit about the mission and the history and the work of the IACD. We've also migrated everything over to a new site on SoundCloud. If you're hearing this, you will probably already know that, but if you find it through other means, I encourage you to take a look at soundcloud.com/the-cd-podcast. All the content is now over there. But to today's guest, I have the very great pleasure of Professor Martin Webb of the Department of Social Policy and Social Work at the University of York in the north of England. Welcome to the podcast, Martin.
Hi, Russell. Thanks for inviting me.
What do you do at the Department of Social Policy and Social Work at York?
So my role is a dual one of research and education. My role is to work with colleagues in providing qualifying social work education. So we have undergraduate and postgraduate programs in social work, and we've also got some post-qualifying provision as well. I have a small research centre called the International Centre for Mental Health Social Research, and we've got a number of projects running at the moment. My main research interests are around developing and evaluating social interventions, approaches which we can use within and outside of health and social care services, primarily with people with mental health problems, but with other people with other needs as well. My main aim in the research programme, the research centre, is to improve practice so that we can improve outcomes for people. And I think in my work that the two fit together very well, that the research informs the teaching, and my engagement with students and practitioners through that informs the research.
And I had sort of lurked, I think is the internet internet term for it, reading your blog for a couple of years that features some of the very topics that you've just referred to. And I was always interested and curious when I would see reference to either maybe overt reference to community development, community approaches, things like that, or whether maybe it was using language that sounded like it was related to community development practice, if not necessarily explicitly referring to CD. And there was one in particular around sort of social prescribing that caught my eye before Christmas at the end of 2021. So I sort of reached out and cut a long story short, here we are. But social prescribing is something we've covered previously on this episode when we've spoken to a couple of community organisations who have that as part of their sort of portfolio of work, and more specifically but through a Scottish lens with Sharon Sweeney from the University of Dundee in episode 23. And cards on the table, I've always been very supportive of these sorts of approaches, but slightly reticent as to what does the community get out of them. Mm-hmm. Clearly, if individuals are, you refer to sort of mental health research that you're involved in, my sort of reticence is that if those individuals are getting something out of a social prescribing approach and their mental health is easier for them to manage, then great, and I'm not knocking that for 1 second. But I'm kind of interested, when you aggregate that across maybe all of the individuals going through and all of the sort of the beneficiaries of those sorts of social prescribing activities and approaches, what does the community similarly, in that kind of aggregated way, get out of these? And then kind of think about what's the capacity required in the communities in order to keep supporting and helping and providing benefit to the individuals. And that's always been one of the things I've had some slight reticence about. And with this podcast, more than happy to be shown and proved that is the case, and there is that kind of investment and that resourcing of communities in these initiatives. Yep. Part of the whole learning about it, really. And it seems to me that's something that is part of your approach and your take on this concept of social prescribing as well, isn't it?
Yeah, absolutely. Coming from a social work background, I approach the notion of prescribing with a little bit of caution. It's very medicalised in tone and meaning, and it fits into a primary care context where you would go and see your GP, you would walk out with a prescription. Social prescribing is broadening that to basically say to people there are other options. You don't need to just pop pills. There's more than therapy that can help. And I think that's a really important message. And that's why social prescribing is I'll come on to its limitations, but it's a useful concept because it is saying there are other things that are good for our well-being. Many people have talked about the benefits of green and blue spaces for our well-being, open spaces. We've learned a lot about the importance of physical activity for our well-being during the pandemic. During the pandemic, we've also learned a lot about the importance of social connections and how that's important for our well-being. Loneliness, social isolation have been very high on the political agenda, public consciousness for the last few years as well. All of these can be addressed outside of the realm of therapy, medication. So social prescribing is basically saying that there are other options out there for people, which, it's a good thing. It's important that message is there. So the government has invested heavily through the NHS plan in primary care networks in establishing social prescribing link workers working either out of primary care practices or within the voluntary sector but connected to GP practices. And these link workers are connecting people to these opportunities within their local communities, whether that's local clubs, societies, local businesses, and other opportunities to get people involved in activities and groups and resources that can have an impact on their well-being. And some of the early research has indicated positive outcomes of engaging with these activities, gym referral schemes, books on prescription, and so on. Evaluated positively, people tend to appreciate them and tend to like them. But really, as you've hinted in your question, and what is behind our model, which I'll go on to talk about, is very much the concern about the capacity for the community to provide these activities and resources. There's almost an assumption there that people can just join these groups and they are self-sustaining, that they've got enough resources to manage an influx of people, that they have an understanding of mental health and well-being, that they are free of stigma and discrimination. And of course we know that community groups, voluntary organisations, by and large, really wonderfully welcoming, accepting places. But for some people, they can be challenging, they can be problematic. And what we find from the community and voluntary sector largely is a lack of resources, a lack of investment, and a lack of kind of help from the statutory sector. Voluntary organisations are constantly submitting grant proposals, seeking funding for the next initiative, and there's never enough resource to provide for their local communities. And therefore, with the social prescribing, the big concern is how are communities, voluntary organisations going to support people who are being referred into the groups without resources and also without planning. And that's really why we've tried to conceptualise a different approach or a supplementary approach to social prescribing, and that's really what we've developed in terms of community enhanced social prescribing.
Yeah, and for me, it's where maybe community development work helps to sustain some of those organisations, helps them to access additional resource, does some of that capacity building that allows groups to be able to continue to meet the need and the accommodation of new people and things like that, which I think will surface throughout this conversation. There's a terrific quote that I return to from it's Stephen Yeo, Yeo, Stephen Yeo, who talks about communities as full of awkward elbows. And I think anyone who spent any time in communities will understand that in whatever capacity, whether it's their own or the people's communities, paid, unpaid capacity, or whatever. And I guess there's a rough and a smooth with that. There's that's a warts and all kind of take on it. Does or can you point to examples of where social prescribing, has conceptualized what it thinks, what it means and understands by community, or has that been something that has perhaps, been assumed or has sort of been conveniently sort of glossed over? Because it's a term you see an awful lot, clearly. It's a term I will use an awful lot in work and in context of this podcast, but it is a contested term. You've pointed to an example in terms of how people might feel less welcome than others coming into certain community spaces and community settings and so on. How is it conceptualized, this word community?
And I agree with the question, really, and what you're inferring with the question, in the sense that community is not necessarily conceptualized sufficiently in the NHS plan, where the social prescribing features. And also in, I think, largely in a lot of the work of the link workers. Now, I'm not going to be too critical of their work. So as I'll talk about, we're working with some who have a really good understanding of community, and I'll use them as an example. But community is a really difficult notion, and I think communities are difficult places as well, because they feature both similarities and differences. There are homogenous groups of people who are largely similar or share characteristics within any given community. And, I'm not just thinking about a geographical space. A community could be a community of interest. I'm in a cycling club, for example, and within the cycling club there is a community of people who are interested in cycling. Now, I wouldn't necessarily want to go out on my bike with all members of this cycling community, partly because I can't keep up with most of them, but also, not everyone gets on, and that's perfectly natural. People have friends, people have people who they're closer to, and people are different, even within that kind of homogenous group of similarity that we've all got an interest in cycling. As a community, we're quite diverse. We do different jobs, we have different outlooks on life. In a geographical community, you can find even more diversity. So most of us live in villages, towns, cities, in groups of collections of people who are brought together for a whole variety of reasons, whether that's because of planning decisions in terms of property prices, it could be allocations of social housing, choices to live in particular communities. So there are particular homogenous communities, either very rich, very poor, somewhere in the middle. Most communities are much more diverse, with people with different interests. And I particularly like the quote that you mentioned in terms of the sharp elbows. That's quite natural. The people are kind of not quite defending their space. That's probably a bit too harsh, but are looking after theirs, looking after their own. So in communities, you will find elements of diversity, elements of similarity. And I think that complexity needs to be understood when we are looking at engaging people with community groups or with the notion of community, because there are barriers for individuals at the individual level to engage with those communities, but also there needs to be a thorough understanding of the dynamics within the communities in order to support and develop them and to manage that process of engaging people with them. So in our work around social prescribing, we're working with an organisation in Trafford, in Greater Manchester, called Blue Sky. And Blue Sky have the contract from primary care to run their social prescribing link workers. And they employ wellbeing practitioners who have I think a well-advanced understanding of what community means and is. And they use and they draw upon community development paradigms in supporting the development of local groups to meet local needs, providing them with support, helping them to, like you've mentioned, apply for funding, developing a little bit of capacity. And those local groups are meeting that local need, but also they've got a good understanding of how people can get along and how sometimes people don't get along, and managing some of those dynamics. So as social prescribing link workers, they are, I think, well positioned to navigate the complexities and the dynamics of the communities in which they're working.
Yeah. And those themes came through in the episode that we did with Nick Andrews from Swansea University in Wales. I'm sure you're familiar with Nick. And he's got a network called Small is Beautiful, and it's a lot of community organisations, grassroots organisations, also alliances. So it's almost in some cases the rejection of formal sort of structures and governance arrangements in any kind of legal sense anyway, that's more around kind of alliances and collaborations, a bit more organic. Yeah. And although we focused primarily on the role of storytelling in social care and how useful storytelling is for sharing knowledge, retaining knowledge within systems approaches, it was clear that some of the examples that Nick was referring to and able to draw on were from very low-level grassroots, certainly more bottom-up than top-down conceptions of what social prescribing might be, that was informed much more kind of naturally and organically by the communities that these organisations were and these individuals were living in and working in, and between. It was a couple of examples in rural parts of Wales, for example, where maybe it's territorially quite a large area but dispersed population. It was really interesting, but it was also really quite enthusing because it seemed to reject a lot of the language that and I'm not going to claim to be anybody with any sort of clinical expertise or background in health, but the terms that sometimes this huge kind of NHS kind of monolith can impose on communities and impose on community groups and impose on people, some of the jargon, they seem to not reject it, but it just wasn't really part of their lexicon. It wasn't part of how they spoke. But actually what they were achieving and what they were helping people with were very much what a public body's social prescribing program would also want to achieve, but using a different lexicon, as I say. Going off on a slight tangent there, but that was episode 27, I think it was, with Nick, and a really fascinating listen, particularly on the use of storytelling as a methodology for evidencing outcomes, if nothing else. So the model that you've referred to is informed by and builds on some other work that you've been involved in around what's called connected communities and also connecting people. Tell us a bit more about those.
So the first thing to say is that this is a collaboration with some colleagues at the University of Central Lancashire. I've worked a lot with Professor David Morris, for example, his colleague Julie Ridley as well. And Paul Thomas has informed the model which we've developed together, largely built upon these two other bodies of work, as you mentioned, connected communities and connecting people. Connected communities is an approach which David and his colleagues have used in working with communities to map local assets, identify local need, and gain a better understanding at a local level about the strengths, assets, resources, but also the needs within communities, taking a social network analysis approach. They've produced some really interesting social network maps, diagrams that map out the connections within communities. And I really love using these in teaching with students and talking about the nature of community and posing questions such as, who do you think within a local community is the most connected person? And we have a discussion about particular positions of prominence within a local community. And in some of the research that David has conducted, for example, it's the person who runs the pub quiz has the most social connections. And I throw in with a little bit of irony that our local pub landlord just down the end of our road is also at the moment the mayor, and he's a very good example of somebody who has the connections at both that informal level. People are coming in and out of the pub, but also at the formal level in terms of his civic responsibilities. So the social network maps are really helpful in describing what a community physically looks like in terms of the social connections, identifying the groups who are better connected, and also the patterns of isolation and people who are disconnected from those wider networks. And we are bringing that approach to taking a helicopter view of communities to a model of connecting people, which I've developed with colleagues to focus social work and healthcare practice in basically supporting practitioners to look beyond the services which they're providing and supporting people to make the connections within communities. Really largely what social prescribing link workers are doing. And connecting people is a step-by-step approach that you would work with an individual who may be isolated, may be lonely, maybe needing to have more people in their life for their well-being, maybe for other reasons as well in terms of support and care. And it takes the practitioner through a process whereby they are having conversations with the person about the people that they're connected to already, what their network looks like, strengths and weaknesses within that and the gaps, opportunities for new social connections. Conversations are mainly focused around an individual's interests, activities, maybe things that they've done in the past, things that they would like to start up again. And then an outward focus on the local community or communities of interest that the person may want to engage with, and developing an action plan with the individual to support them to establish those connections. And most of connecting people is focused on the barriers which have previously prevented that person from making those connections and stepping out and trying something new or engaging with the local groups. And it links back to what I was saying earlier about the diverse nature of community and some of the difficulties that people experience with communities. The process is so that the practitioner, person working with the individual, would offer that support, or at least find other people who can provide that support for the individual to engage with those groups and networks. So in Community Enhanced Social Prescribing, we're bringing the two models together to really inform social prescribing practice. And to make it work and to make it feasible within a primary care network, we're establishing a community panel which does the community mapping. Now, most voluntary sector organisations have a reasonably good network in terms of their connections with other voluntary organisations and other community groups. And often within areas there is an organisation which has that helicopter view about what organisations there are within that particular place, whether it's a volunteering bureau, whether it's some sort of voluntary sector capacity building group, or it might even be the local council, the statutory organisations that have that view about what's going on. But what David and his colleagues really identified in connected communities is that there are a host of informal networks, things that don't necessarily get written down, don't get recorded, but in the network mapping really were illuminated in terms of how people were connected. So what we're planning to do with this panel of volunteers drawn from the local community is to map out some of the hidden resources, the hidden networks, the hidden collections of potential assets that are there within the community, which could benefit social prescribing link workers in terms of new referral routes and sources. But really at the same time, it is about that building capacity, and it's identifying where the needs are within that local community, that the voluntary organisations may have a view on that already, but there might be unmet need. And the idea behind the panel is that they are having conversations locally about what people are saying, what people are thinking about, what is missing from that particular community. And the panel, we would aim for it to become have a little bit of advocacy really in terms of on behalf of that local community to say, there are these hidden resources which could be utilised more, but they would need a little bit more funding, they need a little bit more assistance, and also there are these needs which need to be met. And really the next stage of the process is that the community and voluntary sector organisations connected with the panel are working locally to try to establish new groups, new resources to meet those needs, and also to bring in additional resource from the outside. Now you can tell by the way I'm talking about this that it hasn't yet been done, and we're at the process of we're at the stage of testing this. So we're establishing a community panel in Sale in Greater Manchester as part of the Borough of Trafford with Blue Sky to test whether this model will work, whether it's feasible, and whether we can evaluate it.
Those less formal networks, the less formal ways of doing things, the stuff that you said that's not written down, it isn't codified and things like that. Again, it reminded me of something that Nick and I chatted about, and why storytelling is potentially such a useful methodology for helping to surface some of those more kind of obscure and hidden things. Certainly obscure and hidden maybe to those of us who don't spend time in those communities. Obviously they can be very prominent to people who are immersed in them. So how do you go about testing the feasibility of this sort of model?
So the feasibility needs to be tested at two levels. First of all, is it feasible to get the model set up? And secondly, can we evaluate it in a way which produces generalizable evidence? So we have chosen to work with Blue Sky because we've really noticed over the years, we've done some previous work with them, that as a voluntary sector organisation, it's well connected into the local community. It has the opportunity to put the model into practice with having linked workers that they host, that they employ. And also it's connected, its connectivity with the local community is very, very strong. It kind of gets it. It understands it. The organisation as a whole is oriented towards developing community and supporting people with well-being needs. So for us, it was a perfect fit in terms of testing out the model to see whether it would work. But some of the feasibility elements are: can we establish a panel? Will people give time to give their expertise? What kind of support do we need for the panel? How do we map? What tools do we use for mapping? Can we get the wider community engaged in this at all? We're planning to share the asset maps with the local community, so perhaps using Google Maps, perhaps using something physical which we can put on notice boards within that community, within GP practices and community centres and so on. So does that work? Does the community take any notice of it? Does it matter? And does it make a difference? And the evaluation is looking at two levels. For the individuals who are referred through social prescribing linked workers to local community groups, does it make a difference for them? So we're using some accepted, validated measures of well-being, other individual outcomes such as loneliness, access to resources within social networks and so on. And we're also looking at a community level. Does it do anything for community well-being? And this is an element which most social prescribing evaluations don't look at because it's looking at the outcomes for individuals. We're concerned also with the outcomes for the community as a whole. So we're undertaking some community surveys to see whether people's perceptions of community well-being within the area as a whole changes over the 2 years of the project. We've got a comparison site as well to see in comparison whether that works. The ultimate aim is that we could undertake a larger scale trial, not just in one site, but in other sites as well, to see whether this could potentially be rolled out even further. This initial research is funded by the National Institute for Health Research for Social Care programme, and the funding from the social research from social care is really looking at the preventive nature of these approaches and interventions within communities, that we feel that it will support their independence, interdependence without the need for formal social care. So you might wonder why a social worker is becoming involved in this, and really my motivation to work with communities and to think about community development issues is that I think people get a lot of care and support from within their own communities, and social work tends to deal with people who need a lot of individual care and support, and which maybe the community cannot provide, so specialist provision. So for me, it's all about identifying how communities can be strengthened to support people whose support needs can be met within the communities. And I think it's really, really important that social workers engage with that. And hopefully through initiatives such as this and other work that I've been doing, we are changing that message a little bit about what social work is all about, that it should have a stronger engagement with local communities.
I saw a blog, I think it was a social worker based in, I want to say Camden in London, certainly in London anyway, and she referred to social workers being the means of constructing some scaffolding around somebody and their family, but it can be dismantled when it's needed, but then dismantled when it's not needed. And it's this sense that it's there to, that sense of scaffolding around providing structure and something that is secure. I thought was quite interesting, and I as I say, don't come at these things from a social work background. But you preempted my question then, Martin, in that a lot of how you were talking was how I hear community workers and community development practitioners talk. But of course, coming at it more from in a discipline sense, and I'm maybe suggesting these two disciplines are further apart than they actually are, I suppose, but coming at it from that more traditional social work discipline. Yet for much of this I've been talking like community workers talk, certainly in terms of the reference and the conceptualization of community, and certainly the understanding of community. Another phrase, Raymond Williams, the great late Raymond Williams, referred to that term community as warmly persuasive. It's hard to argue with the word community sometimes, yet as you say, it isn't inevitably perfect all of the time for all people. So I need a bit more sort of realism with these things. If people want to get in touch with you, Martin, interested in this work, interested in hearing about how it unfolds, how the feasibility works, but what would be the best way of doing that?
Well, I'm available by email, martin.webber@york.ac.uk. I'm on Twitter, mgoat73, and as you mentioned, I've got a blog, martinwebber.net. So any of those ways, I'm very happy for people to connect with me. I do update the blog with developments in my research, so that's a good place to find out about the progress of the study.
Martin, absolute pleasure speaking to you. Really grateful for making some time available to chat with me as well. Drop some of those links into the show notes with this on SoundCloud, as I say, and it would be great to keep in touch with the work. It's something I'm particularly interested in. I think it certainly deserves to succeed, and hopefully it'll catch the eye of those people that it needs to. Certainly within the NHS, within the public sector, within social care. It resonates very much as well with some work I'm practically involved in with a community organisation in Cardiff, in Wales, and maybe there's another conversation in relation to that as well. But thanks once again, Martin.
Yeah, definitely. Well, thanks very much for inviting me. It's been good to chat it over with you.
Thank you for listening to the Community Development Podcast. You can follow the podcast on Twitter at comdevtpodcast, COMMDEVT podcast. And to support the podcast and help it share learning, connect the workforce, and raise the profile and the merits of community development approaches, why not become a Patreon at patreon.com/the CD podcast.